Hello, everyone. Welcome back to our morning session at the fourth International Symposium of Complications in Implant Dentistry. I'm again so happy to be the host of another my dear friend, Darcio Fonseca from Portugal, Lisbon. He is with us today, and thank you for accepting this invitation. And the topic that Darcio is going to talk about for us is about complications of partial extraction therapy, which is a hot topic these days. And we have now a lot of confirmed data in long-term success of this technique. And I think because the theme of this symposium is complications and the topic that Darcio chose to talk about for us is complications of this technique, I think it will be not only beneficial for all of us, but also I think it's one of the hottest topic of this year's symposium. So Darcio, welcome to the Symposium of Complications. As a tradition, I will have your CV for all the audience, and then we straightly go to your amazing presentation, and at the end, we will have a short discussion together. Dr. Darcio Fonseca graduated dental school at ISCS Seoul in 1997, fellow in implant dentistry of University of Miami, postgraduate in advanced implantology and minimally invasive oral rehabilitation, invited professor at several universities around the world, and tutor of private hands-on surgery, implantology, and oral rehabilitation courses. He has published many articles in international and Portuguese journals and magazines, and is a speaker at many national and international congresses. He is also the president of ALBI, which is the Brazilian and Portuguese Academy in Dental Implantology. Once again, I have to say I'm so happy to be your host this year in a virtual symposium regarding the situation around the world, and looking forward to hear your amazing presentation. The stage is all yours.
Thank you, Omid. Thank you for the kind invitation. It's an honor and a great pleasure to be with you. Unfortunately, this time it wasn't possible to go to Tehran, but I really want to come back. It's an amazing city, an amazing country, and that's it. The theme of my conference is about partial extraction therapies, the complications. Hi to all. It's a great honor to accept this invitation for Omid Moghaddas to be part of this fourth International Symposium of Complications in Implant Dentistry. It's an honor to share the podium with these amazing lectures, and unfortunately it wasn't possible to do it in Tehran, but we are going to do it virtual online. I would like to thank all the scientific committee for the kind invitation, and to all our sponsors to make this happen. My team is about partial extraction therapies, complications, what went wrong and how to fix it. And we all know that the successful of implant in therapy, as we know, today it's not merely a pursuit of osseointegration, but a full of integration of healthy and aesthetic peri-implant tissues framing the prosthesis. So for the socket shield technique, we have some indications, and the indications are this: it must be done in the socket type 1. With teeth without mobility, with intact buccal bone, with healthy PDL. And it's a technique that was designed for make immediate implant. And it's very useful in the aesthetic zone, especially in cases with the buccal bone with less than 1 millimeter. We all know that the buccal root fragment preserves the buccal bone. This is what's described by literature for many authors like Kersler, for Glockler, Bomer, Gluckman, Salama, Dutoit, etc. And if you have these indications, or if you use these indications, you are going to avoid some kind of problems, but it's not enough. Sometimes all the surgical techniques have problems, and the socket shield technique had problems too. So I'm going to show what are the kind of complications we can have, the early and late complications, and the surgical and prosthetic complications. Well, the complications in partial extraction therapy could be separated in two parts. One are the prosthetic complications, and the other are the surgical complications. And in both, we have the early complications before the definitive restoration, for example, and after the definitive restoration. You can have early complications with the provisionals or with some kind of customized healing abutment, and you can have complications after you deliver the final prosthesis. And we have some diagnostic errors that can be nominated. For example, the error in assessment of the root condition, the error in assessment of radial position of the tooth, and the error in assessment of buccal bone morphology. If we are talking about the error in assessment of root condition, we have several several parameters that we need to be careful. For example, if you don't have the buccal plate, if you have absence of the buccal plate, or in a socket type 2 or 3, you cannot do the socket shield. It's a contraindication. Sometimes the root length, it's important because you need to have the root length at least 2/3 of the root, of the length of the root. And sometimes we see lots of socket shields made in a very, very short shields. And this kind of short shields can give us some kind of complications. For example, passive eruption of the shield, or you can, if it's very thin, you can have, for example, a resorption of the root, or even if you have some bone contact with the implant, sometimes in the implant insertion, in implant placement, you can have some mobility of the shield, for example. If the root have caries, and the caries are very deep, maybe or are deep or more deep than the bone level, maybe it's not a route that you can choose or make the socket shield, because if you want to make the socket shield, you need to have the shield in a good conditions at the same level of the root, or 1 millimeter of the bone, or 1 millimeter above. So if you have, for example, 1 millimeter below the bone, the shield could promote a resorption of the buccal plate. Of course, the periodontal status. If you have, for example, teeth with mobility, they are not in condition to do this type of procedure. If you have an infection in existing teeth, or tooth, or some periapical lesion, you must be very careful. If you want to do this kind of technique, you need to remove all the periapical lesion before you put your implant, and sometimes you need to do an apicoctomy and the socket shield at the same time. And this is something, this is, for me, it's a procedure for more experienced implantologists and they need to have more experience with this technique. If you have an external root resorption, it's not available to make the socket shield technique. And even if you have a vertical or oblique fracture, you need to be careful, because if you have a vertical fracture, this technique is for made with no raising the flap, and sometimes these vertical fractures can hide a fenestration in a buccal plate. So you must be very careful to evaluate the vertical or oblique fracture before you proceed with this procedure. For example, if you have vertical fractures like these, and you have some kind of movement of the buccal part of the shield, of course, this is not an indication to use this kind of technique. In the erroring assessment of the radial position of the tooth, you have to be careful with the trajectory of the root and the tooth position. Why? Because sometimes you are going to put your implant, you need to put your implant in the best 3D position, and it's very important to understand what kind of bone you have available, what are the anatomy of this bone, and what is the position of the tooth in this bone. And this is not going to give you another way to prepare the socket shield, but it's going to give you another way to put your implant according to the bone available and the trajectory of the root. For this, I advise to read this article in the Journal of Prosthetic Dentistry from Gluckman and Dutoit, that this is a very nice article that it calls the radial plane tooth position and bone wall dimensions in the anterior maxilla, a CBCT classification for immediate implant placement. And this is very important to understand what are the anatomy of the bone and what are the position of the root in that bone. And you see, for example, there the class 2, it's the most prevalent. So, and the class 2 more prevalent, that means that the implant cannot follow the root position, and you need to put it more palatal. For example, in the erroring assessment of the buccal bone morphology, we can have fenestrations and dehiscence, and we need to deal with this kind of possible complications. Like I'm going to show you in this case, it was a fracture of a canine. The patient comes with this fracture. It was a horizontal fracture, and I prepared the socket shield. I removed the palatal part of the shield. I placed my implant. But when I placed my implant, I realized that the implant was very buccal. So I decided to remove the implant again and make a new preparation. I drill again, and I put the implant a little more palatal. I grabbed the zone, and I closed. And to see the first time that I put the implant, I make this semilunar incision to see where it was my apex of my implant. And I see that I make a fenestration here in the apical part. So I remove the implant, I put it more palatal, and I graft this fenestration with some bone graft, and I use a collagen membrane, and I finish. In this case, I didn't use immediate loading because I had this problem in the surgery. So I decided to make a Maryland bridge, and after I decide to put my final crown. And this is the result here. I have here the healing of the semilunar incision. And this is the X-ray with everything, it's okay. You can have, for example, prosthetic complications. In the prosthetic complications, you have some kind of prosthetic complications. For example, no space for the prosthetics part, the importance of different types of connections according to the shield, it's different. The implant placement, external X, internal, conical, or tissue level, according to the shield is different, depends of the kind of the connection. and of course the abutments that we have available to make our prosthetic part. You need to be very careful with subcritical area, and you never forget that you have to make the S-shaped design of your crowns to give you more space for the soft tissue. For example, this was described by an article by Gluckman et al. In 2018 that it calls the prosthetic management of implants placed with the socket shield technique. And it shows that in immediate implant placement with socket shield technique and loading, the S shape, it's very important to maintain the bone graft and to give you the space for the soft tissue infill. So sometimes you receive this kind of final crown, and you see that the subcritical area, it's very convex. So you need to reshape the subcritical area to make the S shape that it's important for this kind of procedure. So we need to make this. Sometimes you need to do it in your own office, or you need to deliver the crown to the lab to make the reshape. You mark where is the critical and subcritical area, and the lab give you the crown again, but with the right shape. Well, another issue that nobody talks, it's about the different connections with and different depths. So if you have a conical connection, of course, you can put your implant a little more deep, because the design of your abutments are more narrow than your implant diameter. So it's more easy to give you the space for you be with the jumping with the distance from your abutment and the shield. So with conical connection, it's not so easy to touch the shield with the prosthetic part. So you can leave your implant a little more deep, and according, of course, with the soft tissue remain that you have. You need to have 4 to 5 millimeters from the gingival margin to the implant, so it's more easy to do it in the right way. And this is, for example, in a conical connection, the result of a socket shield, and you see you have all the preservation of the buccal plate, and all the soft tissue are completely preserved. But for example, if you make a comparison between the internal X implant and a conical connection, you see here that the level of the both implants are not in the same position. Why? Because here I only can leave the implant 1 millimeter deep according to the shield, and for example here the prosthetic abutments are more wide from the platform of your implant, and in this case I use a conical connection and I can put it more deep, and I give and the prosthetic abutments give me the space that I need to avoid touch the shield. For example, in this case with internal X, with a very wide abutment, you can have this kind of complication in the prosthetic part. Sometimes the abutment is so wide that cannot fit in the connection in the implant. So you need to remove some bone to give you the best assessment of your abutment. And but sometimes this is a complication for the socket shield, because this abutment is so wide that's going to give pressure in in the shield and in the buccal plate. For example, if you have a tissue level, you know, for example, that you need to put your implant in the same level of the bone, and you cannot put it more down. And in an external X, you know that, for example, you are going to put the implant in the same level of the shield, and not more deep than this because of the prosthetic abutments. And we all know that the shield must be, according to the bone, 1 millimeter above. If you are doing the technique like Mitzias, Mitziadis, and Ersler say, or at the bone level, if you do it like Salama and Blackman and Dutoit preconize. For example, for me, if I have if I need to choose, I put all my shields at the bone level because I want to avoid some other type of complications. And how to avoid soft tissue collapse with the prosthetic abutments or with the prosthetic part? Well, you can use the socket shield with immediate provisional. You can use the socket shield with customized healing abutment. You can use the socket shield with healing abutment, or you can use the socket shield submerged with the cover screw, but you need to do a soft tissue graft. This is the four different examples: immediate provisional in a socket shield, using a healing abutment and a Maryland bridge. Here, using a customized healing abutment like the cervical system, the VPI cervical system, or you can use only the cover screw, and you need to do some soft tissue graft to protect your graft and your socket shield. Well, in the surgical complications, we have several surgical complications, like the shield with the apical part left. If you left the apical part of the shield, you can have a posterior infection. So it's something that you need to avoid. You need to remove the apical part of the shield in all the cases that you do the socket shield. If you have the shield too short, you can have movement of the shield, and you can have passive eruption of the shield. If you have implant touching the shield, it's a problem too, because for two reasons. First, you don't give you space for the new bone formation, and second, you can touch the implant. The implant can touch the shield and provoke micro movements that make the shield move. Not maybe you don't see in the day of the surgery, but after with time you can have some problems with the shield. So it's very important to understand that if you don't have space for implant and shield, you need to put the implant more narrow to avoid the touch of the shield to the implant. Of course, the implant bed position, according to the shield, it's important. So you need to understand that you need to put your implant according to the shield and according to the kind of connection that you have in front of you, and of course the implant 3D bed position. If you don't put the implant in the right position, it's not the socket shield or the PET surgeries that's going to give you the result that you are expecting in the static result that you are expecting in the end, because we all know that an implant bed placed, you cannot have the best static result possible. So all the times you put implant in the bed position, you are going to compromise always the static outcome. Well, if you have apical lesions, of course, you need to remove the apical lesions, and you must be sure that you remove the apical lesions. So you need to do apicectomy and the socket shield at the same time. It's not for beginners, and if you have some doubt, you need to go to remove all the roots, remove all the apical lesion, and you need to go to for another type of procedure. You can have fenestration during the shield preparation, or you can have fenestration when in your implant placement. So it's something that you need to check before you done your surgery. And the most common is an incomplete separation of the shield. Why? Because sometimes the roots are very, very long, and it's not easy, for example, in a canine to separation the buccal part to the palatal part without the right instruments. So when you try to do the socket shield, it's very, very important to use the right tools. You need to have a proper kit to make the socket shield with some kind of burrs, and you need to have a gingival retractor. You need to have some forceps, very, very sharp and very straight, and you need to have forceps for remove roots, very thin, very uh, and for be more easy to remove the palatal part of the root without touching the buccal part. And this is the kind of complications in surgery that you can have. You can have shield exposure, internal or external. You can have shield fracture. You can have shield resorption, shield movement, shield eruption. You can lose the shield, you can lose your implant, or you can lose both shield and implant. So what are the causes of the shield exposure? The internal shield exposure, the shield which has been left supracrestal. This is the most common. So you need to be sure that the shield is not supracrestal, but at the bone level. And the provisional restoration has a bulky emergence, and hence not enough space is left for the soft tissue between the under surface of the provisional restoration and the shield. So for this, it's very important you see the subcritical area before you deliver the provisional crown. In this case, for example, I make these socket shields, and I use always a depth probe to see if I have the shield with 1.5 millimeter at least. And I use here the surgical guide to put my implants. And the implants was placed according to the surgical planning. But in this case, I make some tissue graft. I make some graft in the gap between the shield and the implants, and I use soft tissue graft because I didn't use any kind of provisional. So I decide, like I use the cover screw only. I decide to make soft tissue graft to protect my bone graft, and my implant. This was before, after healing. I see that I have here an internal exposure that I trim, and a few months later, I had enough space to have a new soft tissue, and everything was perfect. With this external shield exposure, the causes are you can have some shield mobility or migration in the buccal direction, or you have, for example, a thin tissue biotype. So if you have a thin tissue biotype, it's very important you have be sure that the shield is at the bone level. How we manage the internal shield exposure? Well, we can trim. This is the most easy. You trim the shield and you make a provisional restoration recontour to increase space between itself and the shield. And the management of external shield exposure. If it's small, you can only trim the shield. But if it's more than 50%, if it's large, sometimes you need to add some connective tissue graft to give to that part of the shield the enough soft tissue for healing this complication better. For example, in this case, I have this shield exposure. It's external exposure. The shield was very high. I trimmed to the level that is the right level, and this is the result after after 1 month completely healed and with no buckle or soft tissue collapse. In this case, for example, I make the same kind. This is like in the limit between the internal and external exposure. I trim, and this is the result after 4 years. Very nice recontour of the gingival part, and here I have mesial and distal papilla. Everything, it was perfect. When you have a shield fracture, what are the causes? Well, you can have an error in the shield prep. You can have pressure during insertion of the implant, or you can have excessive pressure for the restoration, from the restoration. And how to manage? Well, we remove the loose part remove the entire shield and graft. But sometimes depends of the extension of the fracture. For example, in this case that I'm going to show, I did 3 socket shields, and I realized after I placed my implant, it was a guide surgery, that I have a break. I have here a broke shield. I have a fracture here. It was in the insertion of my implant, but this part, it wasn't. It was stable. It wasn't with any kind of movement. So I decided to not do nothing. Like in the Bomer and Ursler paper in 2015, he showed that he promotes a fracture between the shield to see if they are going to have new bone between the shield, the 2 parts of the shield. And that's why I didn't remove the part that it was fractured. And here it was the healing with no problem. I have here no buccal collapse of my ridge and soft tissue. And this case was in the full arch. And this is the result of my full arch with the PET surgery. And in this case, I had a fracture here in this shield. If you have shield resorption, what are the causes? Well, we can have an improper shield prep. It fits very thin, less than 1 millimeter. You can have a resorption of the shield. Or even you can lose the shield because it's so thin that it's more easy to, with any kind of pressure, it could move. So how you manage this? Well, the first, it's avoid to make the shield with less than 1.5 millimeter. And if there's a lack of soft or hard tissue, you need to graft. You need to remove. You need to graft the part that it was resorption. If you have any kind of shield movement, the causes are Well, you can have, if you have a tooth with grade 1 mobility, grade 1 mobility prior to the procedure, for example, the vibrations from the drill to the Schechter during the shield preparation. If you have a thin shield, if you have contact of the shield with implant during placement, if you don't have buccal bone, it was one of the causes of the shield movement, or if you extract, if you have a bad extraction technique that can promote the movement of the shield. What are the, of course, if you have excessive pressure from the restoration, you can have, for example, a ridge fracture, and you have a shield movement and the loss of the ridge. How to manage this? Well, first you remove the shield. Maybe you can preserve the implant. If it's not possible, remove the shield and implant and use conventional post-extraction immediate placement protocol. In a case like this, for example, that I decide to make here a pontic shield between two implants, when I place this implant, I have here a fracture of the ridge and I have here a movement of my shield. So in a case like this, you cannot preserve the shield, and you need to remove the shield and make another kind of procedure. If you have shield eruption, you have some causes. You can have passive eruption, and you can have foreign body reaction. You can have foreign body reaction. The management of this kind of complications in shield eruption is you need to trim or remove the shield. In this case, for example, I have shield eruption and I have some tissue invagination and buccal collapse. So I prepare my socket shield in the bone level. I place my implant. I see that I have a gap between my implant and my shield. I see that my shield have 1.5 millimeters, so everything it's okay. In this case, I graft. I decide to not make immediate implant placement, immediate loading in this case. So I use a Maryland bridge. I use here a collagen sponge and a Maryland bridge. And this is the place of my implant. And when the patient comes to make the final impression for the final restoration, I realize that she had here a buccal collapse. I have here some collapse of the soft tissue. So I remove the healing abutment and I see that I have something that it's not well. So I trim the shield. I have here soft tissue invagination, and I have my shield are not in the right position. So I trim my shield. I put my healing abutment again, and I suture, and I wait for have the opportunity to make the final restoration. When I make the final restoration, these are healing and with the best result. Maybe in a case like this, you can make, for example, you can use a new soft tissue graft to give you more volume here in the buccal part. This is the procedure, the X-rays. This is the root, and here the socket shield, the implant placement, and the final restoration with my final crown. So when you lose your shield, you can have this kind of causes. You can have a shield fracture, and you need to remove the shield. You can have shield resorption. You can have shield eruption, and you need to remove it later. you can have some trauma or some kind of infection. And the management is when you lose your shield, you can graft, or only with soft tissue or with bone graft. In these cases, you don't lose your implant, you only lose your shield. And if you lose your implant, you have two kinds of problems: trauma or infection. The management is you can replace your implants at the same time. You can graft only, or you can graft and or you can graft and after you can place your implant in a few months later. In a case like this, for example, I use it was a central incisor fracture. I make the preparation for my socket shield. I go through the canal. I make the mesial and distal cut. I remove the palatal part of the root. I prepare the buccal part of the root with 1.5 millimeter width. I decide to put, in this case, a zirconia implant. But when I place my zirconia implant, I see that my connection don't allow me to put the implant more deep than the level of the shield. So I make immediate placement, immediate loading. And this was 1 week later. Everything, it was okay. I was happy with the result. After a few months, I remove the crown and I see that I have here an internal exposure. I reshape the internal exposure and I go to my final restoration. Well, my final restoration have two problems. First, this abutment is too short. The collar, it's too short, and maybe it's necessary a collar with more length, with more millimeters, and the abutment is wide comparing with the implant platform. Well, I put the final crown, a zirconic crown with layer, and the patient comes 3 months later to check everything. It was okay. I remove the crown. I see that I have my soft tissue completely preserved with mesial and distal papilla. I was quite happy with the result. But when I go for the final restoration 6 months later, I see that I have the same internal exposure. But when I decide to do, because the patient comes with the crown a little loose, so I decide to give torque to the implant, and I lose my implant. So I remove my implant. I clean the socket very well. I see that the shield is it's not moving, and I decide to put another implant at the same time. And this is the surgery. I reshape my shield. I put the implant. I see that I have a gap between one thing and the other. I make some bone graft, and here I think I had a problem, because I make again in this patient immediate loading. And some months later, the patient come and he say that the provisional crown was a little loose, and I decide to remove the crown. And if you see here, everything looks very well, very, very well. But the truth is that the implant is gone, is completely, I lost the implant because when I give torque to the implant, the patient had pain, and so I see that I didn't have a really good osteointegration. Despite this result, and the result is amazing, of my soft tissue, I lose the implant. So in this time, I decide not put a third implant. So I decide to clean. I didn't lose the shield yet, and I make some bone graft and a Maryland bridge, and I'm waiting for have the time, enough time to decide what I'm going to do after. If you lose your implant and your shield, how you can manage this? Well, you can remove your shield and replace the implant. You can graft, only graft, or you can remove your shield and implant and graft and place an implant in other surgery. This case, for example, we prepare to make the socket shield. Here I remove the palatal part of the shield without touching the buccal part. You see the shield preparation was very long, so I had a very long shield. I place my implant, I graft the gap, and I decide to make immediate loading. And after I make the immediate loading, the patient comes with the tooth moving, but she's not come when this happened. She came 2 months later. So we lost the implant and we graft to make a Glockner technique. But when the patient comes to place the implant a few months later, we see that the shield was moving, so I need to remove the shield too. So I remove the shield, I remove some bone graft that it's not integrated, some particles, and I decide to place another implant with no socket shield. So I remove the shield, I place another implant, and that's it, finished. I place the crown, and I have my mesial and distal papilla too. So, how to prevent the complications? Well, first, the full thickness flap mustn't be used, especially in the static zone, due to soft tissue loss. The soft tissue must be protected with a retractor or elevator during the shield prep. It's very important for not cutting the fibers and promote the bone loss. The shield coronal internal area must be beveled, allowing more space for the restoration and better gingival transition. The emergent profile should be S-shape. And I would like you to thank you and to visit us at the Be Learning Education in Portugal. Here is my contacts of Facebook, Instagram, and my mail. I would like to thank to Omid again for this kind invitation for this amazing symposium. Thank you very much.
And thank you so much, my friend, for your beautiful, comprehensive presentation on the topic, for all the steps that you showed to us very not only briefly but comprehensively. So I have a few questions regarding the presentation. I think it will be good also for the audience. You spoke about complications that may happen regarding partial extraction therapy. And my question will be on socket shield.
Yeah.
I mean, the category of socket shield, not Pontic shield or root submergence technique. So usually one of the complications, as you mentioned, we may face is the exposure of the shield. And
Yes.
talked about the principles that we should know. So I want to ask you this way. Do you think that if the patient is thin biotype, the risk of exposure of the shield can be higher? Or can we say
Yes.
that if we do the protocol right, the risk of exposure will be the same between thin or thick biotype? What's your idea?
Well, this is a very good question, and this is important to explain, because you know that we have two kind of ways to do the socket shield. Or you put the socket shield at the bone level, and if you put the socket shield at the bone level, even if you have thin biotype, you have less probably of any type of complication or any type of exposure. But if you put the socket shield 1 millimeter above the bone level, maybe in thin biotype you can have more exposures. So that's why me and some of my the people of my group, the PET research group, we decide to put the socket shield at the bone level and not 1 millimeter above the bone level, like Ersler described and Mitzias Mitziadis described in their papers, in these papers.
So now the protocol is to bring the shield to the level of the bone.
The bone level.
Yeah, and thin the shield with the chamfer on top to provide prosthetic space and make sure there is no pressure on the shield to prevent the exposure.
Yes.
So
now it's not only a bevel. Now you can make a bevel or a chamfer.
yeah,
You understand?
yeah,
Or
just
a
to
bevel or a chamfer.
just to
Before
thin.
it was a bevel. It was a bevel. Now we make with the proper burrs a chamfer to give the space for the prosthetic abutments.
Yeah. So the question now is about external exposure, not internal exposure. So with internal exposure, when we reduce the thickness of the shield and provide more prosthetic space, the exposure is going to be minimum or almost zero. But about external exposure, do you think that the biotype can have an effect on the percentage of external exposure or no?
Absolutely. I have no doubt about it.
Mm-hmm.
Even in some cases that it's very important to be sure that the shield is at the bone level. The problem is that this technique is a technique that you usually do without raising a flap. So you need to be sure, you need to have a gingival retractor, or you need to have the tools that are necessary to be sure that the shield are at the bone level. If you don't have, if you are not sure, it's quite common you have an external exposure. Mm-hmm. If you are not sure if the shield is at the bone level. In thin biotypes, absolutely. But it's very easy to solve, so it's not a big deal. You understand?
To grind
it's not
it,
a big problem.
Grind it.
Yes, we can trim the shield to the bone level, and if the exposure is very big, you can make a soft tissue graft, and that's it, finished.
Mm-hmm. And in cases that the shield becomes mobile, I mean, like 2 months, 3 months, or maybe 6 months after the procedure, you do the flap to remove the shield or no?
Yes, of course. If the shield is mobile, you need to remove the shield. No way to leave the shield there. Sometimes you can have, for example, and it happens to me, I have a fracture when I put the implant, maybe with the pressure of the implant placement or the pressure of the multi-unit abutment or something, the shield can crack, can broke. And if it's not moving, I leave. I leave the shield. It happens to me one time, and the result it's okay. It's no, I didn't have any kind of problem. But if the shield have any kind of movement, you need to remove the shield and you need to do another implant placement procedure. Not, you cannot leave the shield there with movement.
And Darcio, my final question, what is your experience? Because I've tried this like maybe 5 or 6 times, the thing that I'm saying now, not the socket shield, like the T-belt technique. I mean, to preserve the roots all around and place your implant in the middle. What is your experience about it?
Well, my experience is zero, and my belief in that technique is zero too. So I think it's the people must be very very careful. The T belt, it's for me, it's not the way. You understand? It's not the way you do this type of technique.
Mhm.
The socket shield, it's okay, but the T belt, it's not okay. And look, you need to understand two three things. First, the technique is very difficult to do it. Okay, it's very difficult. You make a 360 socket shield or a T belt with the same height and the same width in all the 360 degrees. Second, you don't need it in the palatal part. Why you are going to do it? You don't need it. You only need in the buccal part. It's the problem is the collapse of the buccal plate. So and the soft tissue collapse, not in the buccal part. In the buccal part, it's almost you don't need this type of technique. And in the other reason is you need bone. You need new bone. If you are making a shield, a 360 shield, you are not going to give the space for new bone. So it's very easy. You have a failure in a few months or in a few years. So I really don't advise nobody to do the T-belt technique.
Yeah, but one of my questions regarding that is that when the integration happens in T-belt technique, I'm not saying that T-belt technique is superior to socket shield, no, but when the integration happens, why do you think that it may fail in future? Because yes, if sometimes because we are worried about the bone formation around implant, if we place it in a T-belt technique, well, the failure will happen in 1 month, 2 months, or fibro integration, or etc. But when the
Yeah.
integrations happens, why should it fail in future? Because definitely there have been some bone around that implants that made the integration successful.
Well, I don't have experience in T-belt, so I'm only going to answer this question about what is my thoughts about it.
Mhm.
Well, you can have, if you have stability and you have new bone formation between the shield and the T-belt, maybe you cannot have any problem in the future. But look, you can have always, for example, um, you can have a foreigner, a body foreigner response of your body can want to, for example, um, give away this kind of piece of food. And I think um, it's a
More risk,
more
right?
complicated
More risk.
technique, more risky technique, and in the end of what is your what you want to do, and the result that you want to obtain. I think it's not better that if you do the socket shield in the traditional way.
Yeah.
So why do something with more risky?
Complicated.
I it's nonsense for me.
Yeah. Yeah, you're right. I just because I thought about it, so because it's the topic of your lecture, I wanted to know your idea
No,
about.
no, I'm glad for the question, but this is my way of thinking.
Yeah, good. I agree with you. Darcio, I have to say thank you again so much for your amazing presentation,
Thank
for your
you.
time, for joining me in this year virtual symposium fourth time. Definitely looking forward to see you soon and have you in Tehran. So you have to promise me, hopefully after all these COVID-19 situation, and stay
No,
safe
it's
and God bless you.
oh,
Thank you.
thank you very much, and it's a promise that I come back to Tehran. If you invite me, I come again. Okay, thank you very much, Omid. Thank you.
Thank you.
Bye.
Bye.